Hello, I'm Dr. Aishwarya Roy, Junior Resident General Surgery at RG Kar Medical College and Hospital, Kolkata. Today, we are going to be talking about sialadenitis. So, what is sialadenitis? It is inflammation of salivary glands. So, which glands? Salivary glands means parotid, submandibular, sublingual, and also the minor salivary glands. Minors. So, sialadenitis is more common in parotid glands in general. And it is seen around in 10% of cases in submandibular gland. But here is a catch that if the sialadenitis is occurring due to impacted stone or stone formation, that is sialolithiasis, then it is more common in submandibular glands. So, if due to stones, then more common in submandibular gland. Submandibular gland. So now there is a reason behind it. So why is it more common when it comes to stone formation in case of submandibular gland? So it is mainly due to the following reasons. First one being that the nature of the content is more viscous. So viscous content of submandibular gland. Then it has a non-dependent drainage of the mucus. Also, the amount of calcium and phosphate is more in submandibular gland secretions. So, this all ultimately leads to stasis, which leads to stone formation. Now, before we go further, let me talk about another similar term, that is sialadenosis. Sialadenosis. So, what is sialadenosis? It is a non-inflammatory and non-neoplastic enlargement of the salivary gland, which is mainly due to metabolic disorders. Also can be due to diabetes mellitus. It can also be due to malabsorption or malnutrition rather, due to eating disorders. It can also be due to disorders like liver cirrhosis, etc. So we have to remember that sialadenitis is an inflammatory condition, whereas the sialadenosis is a non-inflammatory condition. This is the difference between the two. Now coming back to sialadenitis, so types. So sialadenitis can be of two types, mainly two types. Another one is acute, another one is chronic. Acute means of sudden signs and symptoms and of shorter duration, whereas chronic means it's been there for a long time. Now, first we'll be discussing about the acute part. What is the main cause behind acute sialadenitis? So, acute sialadenitis is mainly because of infection due to bacteria and viruses. Now, why is it occurring? The mechanism involves mainly two factors. First is hyposecretion from the gland, and another one includes obstruction. Hyposecretion from the gland can be due to many reasons, like dehydration, like different kind of drugs like anticholinergic, can be due to beta blockers, antihistaminics, xerostomia, or some post-operative reasons. Now, the post-operative reasons, here there is a term that is known as abdominal mumps. So, what is abdominal mumps? Abdominal mumps is actually sialadenitis which occurs after any abdominal surgery. surgery. Now, why is it occurring? So the mechanism mainly involves two factors, that is use of atropine, which is given to reduce the secretions, which ultimately provides the organisms a very good environment for proliferation, and also it is caused by prolonged NPO state that is there before any kind of abdominal surgery, which results in dehydration, which is again a cause of hyposecretion. So this thing is known as abdominal mumps. Now coming to the causes of obstruction. So there can be different causes of obstructions like calculi, foreign bodies, can be due to strictures. It can also be due to radiation, and it can be caused due to compression by some mass, maybe due to like some cancer, neoplastic proliferation. So these two factors, hypersecretion and obstruction, these two factors together leads to ascending infection. So there is reduced amount of secretion and there is obstruction. So it gives a good environment for the bacteria and virus to proliferate, resulting in ascending infection of the gland. Now, coming to now we're saying that bacteria and viruses are involved. So let's talk about which bacteria and viruses are involved mainly. So for bacteria, the most common is Staphylococcus aureus. It can also be caused by H. influenzae, also be caused by Enterobacteriaceae, it can also be caused by Streptococcus. Now, tuberculosis and actinomycotic infection can also resemble sialadenitis, looks like a neoplastic proliferation. So, this is also a very important point, that TB or actinomycosis may look like a neoplastic proliferation. Now, we'll come and to the point of clinical features of acute sialadenitis. We're only talking about acute sialadenitis now. We haven't gone to chronic part. So, acute sialadenitis, clinical features. The clinical features of acute sialadenitis will include pain, swelling. See, it is due to inflammation. So, all the signs and symptoms of inflammation will be present there. So, it will include pain, swelling. We can see that it is erythematous. It will be tender. There will be dysphagia. There can be fever. And there can be trismus also. Now this trismus, why do we see trismus? It is because submucosal fibrosis inflammation. So there can be erythema, there can be scar also, scar and sinus formation also. Now, why is this erythematous is important and why is this scar important? So we have to understand that erythema can be seen in acute sialadenitis. It can also be seen in case of radiation. Can be seen post radiation. And scar and sinus formation can be seen in case of acute sialadenitis. It is also seen in case of tuberculosis or post trauma. The first picture is showing inflammation or acute sialadenitis in case of parotid gland. Now in the second picture we can see the sialadenitis of the submandibular gland. And here we can notice double chin appearance. The double chin appearance. Due to swelling of the submandibular gland. Now, before we go further, we'll talk about chronic sialadenitis first. Then we'll go to the discussion of diagnosis and treatment. So, let's talk about chronic sialadenitis. So the chronic sialadenitis is mainly of two types. So before we talk about the types, let me make it clear what is the difference between acute and chronic sialadenitis. In acute, there is inflammation. If inflammation is positive, then it is acute, and if it is inflammation negative, then this is chronic type. So we are coming back to chronic sialadenitis. So the chronic sialadenitis is mainly of three types. First is obstructive. Chronic obstructive sialadenitis. This is the most common variant. Second is the chronic sclerosing type. Another one is iatrogenic type. So obstructive means due to any kind of obstruction, which can again be of the following reasons: calculi, foreign body, stricture, radiation, compression. It can also be due to like papilloma, ductal loma, etc. The same reasons applicable here, that those are the obstructive causes. Now sclerosing. Which is sclerosing? Sclerosing is mainly due to autoimmune disorders. Autoimmune disorders. For example, mainly two diseases. One is Sjogren syndrome. Another one is IgG4 related disorder. These are the mainly two causes of sclerosing type of chronic sialadenitis. Now, the Sjogren is associated with CD4 positivity, whereas this IgG4 related disorder is associated with CD4 positivity and CD8 type of cells positivity. This sclerosing type of chronic sialadenitis is also known as, is given a special name, that is known as Kuttner's tumor. It is known as Kuttner's tumor. And there is another type, that is the iatrogenic type, which mainly due to medical causes like surgical, post-surgical or post-radiational causes are included in this category. So before I go further, let me give you another information that the sclerosing type is usually unilateral. That is, it will involve only one side of one side of the gland, like only right parotid or left parotid, right submandibular or left submandibular will be involved. So it is usually unilateral involvement of gland, but can be bilateral also. Now there is another special type, that is eosinophilic sialadenitis. As we can guess from the name that eosinophils are always associated with allergic reactions, so this is obviously associated with allergic reactions. So eosinophilic and as in case any kind of allergy, there will be increased amount of IgE. So the clinical features of chronic sialadenitis will include mainly pain, which is of a typical nature. That is, it will be more during mastication due to stimulation, which is known as salivary colic, and it is mainly induced by meals, lemon juice, etc. So salivary colic is the typical finding of chronic type of sialadenitis. Meal and lemon juice, etc. There will be swelling of the gland, but typical is that the swelling will be reduced near about in 2 hours of food intake. There is food inside the mouth, the secretion will be increased, that will lead to swelling of the gland and also more amount of pain. But when we are done with like the food and the eating, the pain and the swelling will be reduced, because the amount of secretion will be less after around 2 hours. Now there will be tenderness of the swelling, and another important point that we can see is we might see some secretion like pus may be seen. We might be able to see the stone in the per oral examination. Oh, there is another thing. We're talking about salivary colic. There is another colic that is known as lingual colic. There can be irritation of the lingual nerve, which lies in very close proximity to the submandibular salivary duct. So the pain or any kind of irritation to that nerve can cause pain in the tongue. So this is known as lingual colic. So these are the common features of chronic sialadenitis. Now let me go to the histopathological examination. In histopathological examination of sialadenitis, we'll find neutrophils, whereas in chronic sialadenitis, chronic type will have different kind of histopathological pictures. Like for obstructive type, if it is an obstructive type, we'll see ductal dilatation, the gland tissue may be normal. On endoscopic approach, we can see papillary stenosis, stricture, we might see like inflammatory debris, occult stones may be seen. If it is sclerosing type, we'll say lymphatic infiltration, lymphoid proliferation, we might see periductal fibrosis, acinar destruction, etc. Before going to, let me talk about the investigation. So initial investigation will include blood investigation, blood reports like CBC, all common blood reports like CBC and all, count, etc. But the important and extraordinary ones, which is specific for this disease, is mainly the autoantibodies, autoantibody titers, then thyroid levels, ESR, CRP, etc. So the more important part is the radiological investigations. Radiological investigations will include X-ray. Here we can see the stone. This type of X-ray is known as dental occlusion films. Then we can go for CT scan. Here we can see that mild right submandibular gland enlargement with abnormal enhancement. This is another CT image demonstrating that right submandibular space and thickening of the right platysma muscle here. Then we can go for this is a CT scan. Now we can go for USG. So USG will mainly help in understanding the architecture and the blood flow. So this picture is for the parotid gland. And here in the right side we can see that the images are normal, whereas in the left parotid gland we can see that there is more amount of more hypolucent areas, and there is more vascularity, increased vascularity. So this is a case of left-sided sialadenitis. This picture is for a submandibular gland. Here also we can see that the right one has inflammation and the left one is normal. So submandibular gland. Now this is the MRI picture. MRI picture. This is the T1 weighted image and this is the T2 weighted image. In the T1 weighted image, the area is hypointense, whereas in T2 image the area is hyperintense. So by this way we can differentiate Now the next investigation is very much specific: sialoendoscopy, which includes insertion of an endoscope through the opening of the duct. So this is sialoendoscopy. This is sialogram, and here we can see that there is a stricture over here which is causing obstruction, and this is a latest one. This is known as digital subtraction sialography. Digital subtraction sialography. So these are all the investigations that are normally used or currently available for sialadenitis. Now the last part is the treatment part. So for acute sialadenitis, the main treatment is using antibiotics, mainly amoxiclav or clindamycin can be used. Cephalosporins or fluoroquinolones have a better concentration in saliva, so this can also be used. Then the important part is to maintain hydration. We have to stop using generic drugs. Oral hygiene improvement. These are the mainly available treatment methods. With chronic or recurrent cases, if the above methods fail, then we can go for surgical excision of the gland. Now there is a newer method, that is external lithotripsy. That can also be used. Now there are different types of post-operative complications which are important and should be known. Post-op complications are mainly recurrence, abscess formation, and here we'll see fever. Clinical feature will be fever. Then decaying of tooth, due to the lack of protective barrier of saliva over enamel. So that's it for today. So this gives a little bit of idea about the topic of sialadenitis. Now we'll meet for another video very soon. Thank you so much.